Ladies and gentlemen, I'm Mike Mangrum. It is indeed a privilege to be here today and to introduce two cases to you using non-invasive mapping. We will be highlighting not only the non-invasive mapping, but we will show patient workflow and then the invasive procedure. The first case today is a PVC case, and we will be showing off single beat mapping. And the second case is a repeat persistent atrial fibrillation case in which we will be doing phase mapping. The patient is a 71-year-old male with a history of an ischemic cardiomyopathy with an ejection fraction of 25%. He has a history of persistent atrial fibrillation, and we actually ablated him in June of 2017 using the CardioInsight vest. He's had no further recurrence of the atrial fibrillation, but his heart failure symptoms have gotten worse. We noted on his exam, as well as in the clinic, that he was having very frequent PVCs. His PVC burden by a 24-hour Holter was 27%. With that, he was referred to the EP lab for ablation of the PVCs. We decided to use the CardioInsight vest today to map his arrhythmia. The PVC on the 12-lead ECG is shown on the left-hand side of the image, and the Holter monitor with the total PVC burden is on the right side of the image. Please note on the ECG the inferior axis and the R wave in V1 with the early transition. The CardioInsight vest has 252 electrodes. Unipolar signals are collected from each of these electrodes. The patient is brought to a pre-procedure area outside of the EP lab. The chest is prepped and the vest is placed on the patient. Now the vests come in 4 different sizes, and the size is chosen based upon the patient's weight, height, and torso size. There are 3 panels to the vest. 1 is placed on the back of the patient and 2 on the front. We try to maximize the number of good electrode contact, and so the vest is positioned on the patient to allow that to happen. Once the vest is on the patient with good electrode contact, we then connect the signal cables from the amplifier to the vest along with a connection to the ground electrode and a reference electrode. A unique feature of the non-invasive mapping is that the patient can undergo mapping of their arrhythmia outside of the EP lab. We acquire unipolar cardiac signals from each of the electrodes. These are displayed on the acquisition screen on the workstation. Signals are acquired from all of the electrodes which have contact, and different electrode channels can be selected to assure signal quality and for display on the workstation. In this case, we are mapping PVCs. These can be automatically detected by setting up an average RR detection window and setting a threshold within that window to identify premature beats. In atrial fibrillation cases, the windows of AF can be automatically set up and used for phase map analysis, but in this case, we are mapping PVCs. After acquiring electrical information, the vest must remain on the patient, and the patient is then taken to radiology for a CT scan. Patient is gently positioned on the table without moving the vest. Now the CT scan can be done with or without contrast. An important point for these scans is that it must include the entire vest to identify each of the electrodes. The image slices will generally start near the jawline of the patient and extend to the mid-abdomen. We also need to assure that the image window is wide enough to get the electrodes on the side of the patient. Once we are happy with the scan, we can then take the patient to the EP lab. Now we have decided to keep the vest on the patient and use it intraprocedurally for additional mapping of PVCs in the event there's a change in PVC morphology. We can also use it to localize the catheter with pace mapping. In the EP lab, we need to add 3 things under the vest. defibrillator pads, ECG electrodes, and positional patches and electrodes for invasive mapping systems. In this case today, we are using Precision for the case. The placement must be done carefully in order to minimize any movement of the vest and to minimize any loss of vest electrodes. The vest can be carefully folded back if needed, and the black fabric can be cut and the electrodes can then be placed through this cut. The connection cables are run outside of the vest, again to minimize loss of vest electrodes. The connection cables are then secured. The first step is segmentation of the CT images. This is done in two separate steps. Number one is the identification of electrodes. Each electrode is identified to define the heart-torso relationship. Number two is segmentation of the chamber of interest. In this PVC case, we segment both the right ventricle and the left ventricle. The valves are identified, and then the LAD is traced out to help with visually identifying the intraventricular septum and the RV and LV. In this procedure, we also traced out the right coronary artery. The completed segmented model is seen here with both the LAD and RCA identified. We're taking the pre-procedure PVCs and we're mapping them here before we get access. And we're hopefully going to use this to determine what kind of venous access we need or arterial access. Now we are ready to combine the information we collected in the pre-procedure area with the cardiac chambers. Because we are mapping isolated PVCs, we are using single beat mapping. There are different maps that can be created. These can be done with individual beats or can be done with signal average beats for a specified period of time. In the processing, individual signals can be removed if there is noise seen. One map is a potential map. The potential map displays electrical potential in millivolts at all locations on the surface of the heart at any point in time within the map interval. A cine of the map interval may be played to show potential changes over time. The potentials are displayed in a color gradient where white defines the most negative potential values and the dark green defines those areas with most positive potential values. Another map is activation map. The activation map displays activation time in milliseconds for all locations on the surface of the heart. Activation is marked as the maximum negative dV/dt within the user-defined signal window. Earliest activation is represented by red and latest by dark blue. Another map is directional activation map. This map adds spatial information to the activation map and can be displayed with directional arrows. Contours can be added. Additional maps could also be voltage maps, slew rate maps, and propagation maps, but these were not constructed in this case. So we've analyzed the PVC, and it's not clear cut whether it's coming from the RV outflow tract or the LV outflow tract. But we looked at the conduction, basically the conduction velocity, and it seems to be that the left ventricular side has a faster conduction. So we're going to start with mapping in the LV outflow tract and go from there. Let me describe the imaging monitor that you see in the case. In the upper left is the live fluoro screen. Next to it is our precision map. The CardioInsight map is in the top right, and both lower panels are the Claris recording system. We started with using a 20-pole catheter to map the PVCs. We are mapping for the earliest signal. The earliest signal in the LV outflow tract seems to be close to the aortic valve. We next decided to map the right ventricular outflow tract. We were fortunate that during the case, which was done under conscious sedation, the PVCs continued throughout. The earliest signal was similar to the left ventricular outflow tract. We then decided to use a different catheter to try and make sure that we had a complete geometry and have mapped all areas. We are not using intracardiac echo in this case, but this could be helpful to assure we have a complete geometry and are mapping in all areas. With the timing of the left ventricular outflow tract and the RV outflow tract being very similar, we decided to map the coronary sinus. We were able to get the mapping catheter in the great cardiac vein and also the anterior intraventricular vein. The earliest signal from the LV outflow tract, the RV outflow tract, and the coronary sinus was very similar. On this slide, the PVC is displayed on the left-hand side of the screen with the potential maps on top and the activation maps on the bottom. Please note the best pace mapping from the RVOT, the LVOT, and the coronary sinus are displayed, with the best match being from the coronary sinus. We started with ablation in the left ventricular outflow tract at the earliest site. We used a 5 mm non-irrigated tip catheter set at 50 watts and 60 degrees. We were unable to get suppression of the PVC. We then moved the catheter to the right ventricular outflow tract area, and using similar settings, we were also unable to get suppression of the PVC from this location. We then moved the catheter to the coronary sinus at the earliest site and delivered a maximum of 20 watts, and we got initially some suppression of the PVCs, but they returned. At this point, we again reviewed the maps and believe that it's coming from the LV summit, either epicardial or an intramyocardial source. We decided to change to an 8 mm tip ablation catheter, and we placed additional lesions. Finally, in the left ventricular outflow tract, with a reverse curve on the catheter and delivering 80 watts of energy, we were able to get elimination of the PVC. Okay, to sum up the case for today, we started with an outflow tract, what we felt was an outflow tract PVC, and we did cardio insight mapping pre-procedure, and then as he was having frequent PVCs in the lab, we were able to do activation mapping with precision. We mapped actually all 4 chambers, and 4 I mean the RV outflow tract, the LV outflow tract, and we also did activation map very distally in the coronary sinus. First of all, the cardio insight map. The cardio insight map showed that the activation originated what appeared to be between the LV outflow tract and the RV outflow tract, actually. When we did activation mapping with precision, it confirmed that. It showed exactly the same site of activation. In fact, with precision, the very earliest activation was in the coronary sinus, the very distal coronary sinus. So in the end, I believe the actual site of the PVC was probably intramyocardium or maybe epicardium at the LV summit. We were able to ablate it, and we ablated it by the mechanism of targeting all sides of it. We ablated in the distal coronary sinus at the site of earliest activation. We ablated in the RV outflow tract at the earliest activation, and where it eventually terminated was just under the aortic valve in the LV outflow tract. It required the use of an 8 mm catheter and, with 80 watts of power to get it. So I think it was deep in the myocardium, but we were able to successfully get that. And the cardio insight map and the precision map matched.